principle and potential complication of splenectomy. The potential advantage of laparoscopic splenectomy, the benefit of splenic conservation, the importance of prophylaxis against infection following splenectomy. The anatomy of the spleen. The weight of the normal adult spleen is about 75 to 250 gram. Dimension 10, 7, 3 cm. It lies in the left hypochondrium between gastric fundus and left hemidiaphragm. The long axis lying along the 10th ribs. The hilum sits in the angle between the stomach and the kidney and is in contact with the tail of the pancreas. The splenic artery, the tortuous splenic artery arises from the celiac axis and run along the upper border of the body and tail of the pancreas, to which gives small branches. The short gastric and left gastric gastroepiploic branches pass between the layer of the gastrosplenic ligament. The main splenic artery generally divided into superior and inferior branch, which in turn subdivided to several segmental branch. The splenic vein is formed from several tributaries that drain the hilum. The vein runs behind the pancreas, receiving several small tributaries from the pancreas before joining the supramesenteric vein at the neck of the pancreas to form the portal vein. The lymphatic drainage comprises efferent vessels in the white pulp that run with the arteriole and emerge from nodes at the hilum. These nodes and lymphatics drain via retropancreatic nodes to the celiac node. Sympathetic nerve fibers run from the celiac plexus and innervate splenic artery branch. Function of the spleen: immune function, filter function, beating, reservoir function, and cytopoiesis. Congenital abnormalities of the spleen. There is splenic agenesis, which is rare but present in 5% of childhood. Splenomeniculi are single or multiple accessory spleen that are found in approximately 10 to 30% of population. They are located near the hilum of the spleen in 50% of cases and are related to the splenic vessels or behind the tail of the pancreas in 30%. The remainder are located in the mesocolon, greater omentum, or the splenic ligament. The significance lies in the fact that failure to identify and remove these at the time of splenectomy may give rise to persistent disease. Hamartomas are rarely found in life and vary in size from 1 cm diameter to masses large enough to produce abdominal swelling. Non-parasitic splenic cysts are rare. Splenic cyst, classified as primary cyst, which is true cyst, or pseudocyst, secondary cyst, bases on presence or absence of lying epithelium. True cysts of the spleen are very rare and frequently classified as cystic hemangioma, cystic lymphangiomas, epidermoid, and dermoid cysts. These should be differentiated from false secondary cysts that may result from a trauma and contain serous or hemorrhagic fluid. The wall of such degenerative cyst may calcify and therefore resemble the radiological appearance of hydatid cyst. The spleen is also a common site for cyst developed from a severe attack of pancreatitis. Pseudocyst can easily be diagnosed on scanning, and intervention is normally required for symptomatic lesion that persists following a period of observation. Splenic artery aneurysm, infarct, and rupture. Splenic artery aneurysm involve the splenic artery 0.4 to 1% of postmortem examination, twice as common in women, and usually situated in main arterial trunk. Although these are generally single, more than one aneurysm is found in 1/4 of cases. These may be consequences of intra-abdominal sepsis and pancreatic necrosis. In particular, they are more likely to be associated with arteriosclerosis in elderly patients. The aneurysm is symptomless unless it ruptures and is more likely to be detected on a plain abdominal radiograph or scan. It is unusual to be palpable, although a fluid may be present. Rupture is unsuspected in the majority of cases, as it will generally rupture into the peritoneal cavity. The symptom mimic those of splenic rupture. Almost half the cases rupture occur in patients younger than 45 years of age, and 1/4 are in pregnant women, usually in the third trimester of pregnancy. Treatment of choice previously consists of splenectomy and removal of diseased artery. Some surgeons advocated ligation of the proximal and distal end of the sac, allowed thrombosis of the aneurysm, and partial or complete splenectomy if necessary. The procedure has performed laparoscopically with success. Embolization or endovascular stent following selective splenic artery angiography can be considered. In the elderly patient with a calcified aneurysm, there is less risk of rupture and observation may be preferred. In patients with pancreatic necrosis, the treatment will include drainage of septic focus. Splenic infarction. This condition commonly occurs in patients with massively enlarged spleen from myeloproliferative syndrome, portal hypertension, vascular occlusion produced by a previous surgical intervention, such as spleen preserving distal pancreatectomy, pancreatic disease, splenic vein thrombosis, or sickle cell disease. The infarct may be asymptomatic or give rise to left upper quadrant and left shoulder tip pain. Contrast enhanced CT will show the characteristic perfusion defect in the enlarged spleen. Treatment is conservative, and splenectomy should be considered only when septic infarct causes an abscess. Splenic rupture should be considered in any case of blunt abdominal trauma, particularly when injury occurs to the left upper quadrant of the abdomen. Iatrogenic injury to the spleen remain a frequent complication of any surgery procedure, particularly those in the left upper quadrant when adhesions are present. Rupture of malarial spleen in tropical countries. Rupture of the spleen enlarged due to malaria is not uncommon. In such patients, radiological embolization may be preferred if available, and splenectomy should be considered before perisplenic hematoma rupture, a complication that is associated with a worse prognosis. Surgery in such patient is challenging, and early ligation of splenic vessels along the superior border of the pancreatic body should be considered before disturbing the hematoma. Causes of the splenic enlargement, like infective, bacterial, spirochetal, viral, protozoal, blood disease, acute leukemia, chronic leukemia, and others, metabolic, circulatory, collagen disease, non-parasitic cyst, and neoplastic. Idiopathic thrombocytopenic purpura. In the most cases of ITP, the low platelet count results from the development of antibodies to specific platelet membrane glycoprotein that damage the patient's own platelet. It is known as immune and autoimmune ITP, thrombocytopenic purpura. Two distinct clinical types are evident: acute condition in children and chronic condition in adults. Acute ITP often follows an acute infection and has spontaneous resolution within 2 months. Chronic ITP persists longer than 6 months without a specific cause being identified. Approximately 50 to 75 cases per million arise each year in adults compared with 50 cases per million each year in children. Clinical feature: the adult form normally affected female between the age 15 to 50 years, although it can be associated with other conditions include SLE, chronic lymphatic leukemia, and Hodgkin's disease. The childhood form is distributed equally between male and female and commonly present before the age of 5 years. Purpuric patches ecchymosis occur in the skin and the mucous membrane following the trauma or pressure. Examination often reveal number of petechial hemorrhages in the skin. There is a tendency to spontaneous bleeding from mucous membrane, example epistaxis in women, menorrhagia, and prolonged bleeding of minor wound are common. Hemorrhage from urinary and GIT tract hemarthritis are rare. Although intracranial hemorrhage is also uncommon, it is the most frequent cause of death. The diagnosis is made based upon the presence of cutaneous ecchymosis and the positive tourniquet test. The spleen is palpable in fewer than 10% of patients, and the presence of gross splenic enlargement should arise a suspicion of an alternative diagnosis. Investigation: coagulation studies are normal. Platelet count in the peripheral blood film is reduced. Bone marrow aspiration revealed plentiful supply of platelet-producing megakaryocyte. Treatment: the course of the disease differ in children and adults. The disease regressed spontaneously in 75 of pediatric cases following the initial attack. Short course of corticosteroid in both adults and children are usually followed by recovery. Prolonged steroid therapy should not be continued if this does not produce remission. Splenectomy is usually recommended if a patient has two relapses on steroid therapy, or if the platelet count remains low. Generally, this is indicated where the ITP has persisted for more than 6 to 9 months. Up to 2/3 of patients will be cured by surgical intervention, and 15% will be improved, but no benefit will be derived in the remainder. The response to steroid predict a good response to splenectomy. In the acute setting, the severe bleeding has not been controlled by steroid. Fresh blood transfusion and transfusion with platelet concentration before operation is necessary, although these are generally withheld until the splenic vessels have been controlled at operation. Hemolytic anemia. There are 4 causes of hemolytic anemia that are generally amenable to splenectomy. Hereditary spherocytosis. Hereditary spherocytosis is autosomal dominant hereditary disorder characterized by presence of spherocyte red cell. Spherocytosis arises essentially from an increase in permeability of the red cell membrane to sodium, and this ion leak into the cell. The osmotic pressure rises, resulting in swelling and increased fragility of spherocyte. Larger number of red cells are destroyed in the spleen, where there is a relative deficiency of both glucose and oxygen. The clinical presentation is generally in childhood, but may be delayed until later life. Mild intermittent jaundice is associated with mild anemia, splenomegaly, and gallstone. Circulating bilirubin is not conjugated with glucuronic acid and is not therefore excreted into the urine as it bound to albumin. Excretion of the resulting bilirubin complex by the liver favor the formation of pigmented stone. Once the disease manifested itself, spontaneous remission are uncommon. The patient is often pale and jaundiced at presentation. In some families, this disease is characterized by a severe crisis of red blood cell destruction, during which of erythrocyte count may be fall from 4 to 4.5 to 1.5 million per milliliter within 1 week. Such crises are characterized by the onset of pyrexia, abdominal pain, nausea, vomiting, extreme pallor, followed by increased jaundice. This episode may be precipitated by acute infection. Any child with gallstone should be investigated for hereditary spherocytosis and family history. Examination reveals splenomegaly, and the liver may also palpable. Chronic ulcer may arise in adult with a disease. Hematological investigation include fragility test. Reticulocytes are discharged into the circulation by the bone marrow to compensate for the loss of the erythrocyte by hemolysis. Fecal urobilinology is increased as this route excretes most of the urinobilinology. Radioactive chromium labeling of the patient on red cell will demonstrate the severity of red cell destruction. All the patients with hereditary spherocytosis should be treated by splenectomy, but in juvenile cases, this generally delayed until 6 years of age to minimize the risk of post-splenectomy infection. Ultrasound should be performed preoperatively to determine the presence of or absence of gallstone. Acquired autoimmune hemolytic anemia, this condition divided into immune and non-immune mediated form. In the most instances, the cause is unknown and red cell survive is reduced because of immune reaction triggered by immunoglobulin or complement on the red cell surface. This condition is more common in women after the age of 50 years. In half the patient, the spleen is large and 20% of cases pigmented gallstone are present. Anemia is invariably present and may be associated with spherocytosis because of red cell membrane damage. In the immune type antibody which cause the red cell can be detected by the agglutination when anti-human globulin is added to the suspension of the patient erythrocyte. Coombs test positive. The disease on an acute self-limiting course and no treatment is necessary. Splenectomy should, however, be considered if corticosteroids are ineffective, when the patient is developing complications from the long-term steroid treatment, or if the corticosteroids are contraindications. 80% of patients respond to splenectomy. Thalassemia, most commonly as recessive trait. Most patients suffer from beta thalassemia, in which the reduction in the rate of beta chain synthesis result in decreased hemoglobin A. Patients with homozygous thalassemia major frequently develop clinical signs in the first year of life, and these include retarded growth, enlarged head, and with slanting eyes, and depressed nose, leg ulcer, jaundice, and abdominal distension, secondary to splenomegaly. The final diagnosis is by hemoglobin electrophoresis. Blood transfusion may be required to correct profound anemia, but the patient may become transfusion dependent because of the development of hypersplenism. Splenectomy is therefore of benefit in patients who require frequent blood transfusion and if the hemolytic antibody have developed as a result. Sickle cell disease. A hereditary autosomal recessive hemolytic anemia occur mainly among those of African origin in whom the normal hemoglobin A is replaced by hemoglobin S. The hemoglobin S molecule crystallizes when the blood oxygen tension is reduced, thus distorted and elongated the red cells. The result in increased blood viscosity may obstruct flow of the blood in the spleen. Splenic microinfarct are therefore common. The sickle cell trait can be detected in 90% of those of African origin, but most are asymptomatic. Sickle cell disease occur in about 1% of African. Depending upon the vessels affected by vascular occlusion, patient may complaining of bone pain, joint pain, priapism, neurological abnormalities, skin ulcer, or abdominal pain due to visceral blood stasis. The diagnosis is made by the finding of characteristic sickle-shaped cell on the blood film, although this investigation has largely been replaced by hemoglobin electrophoresis. Hypoxia that provoked a sickling cells should be avoided and is particularly relevant in patients undergoing general anesthesia. Adequate hydration and partial exchange transfusion may help in crisis. Splenectomy is of benefit in a few patients in whom excessive splenic sequestration of red cells aggravate the anemia. Chronic hypersplenism usually occurs in late childhood or adolescence, although streptococcus pneumonia infection may precipitate an acute form in the first 5 years of life. Neoplasm of the spleen, like hemangioma, is mostly common benign tumor of the spleen and may rarely develop into hemangiosarcoma that is managed by splenectomy. The spleen is rarely the site of metastatic disease. Lymphoma is the most common cause of neoplastic enlargement, and splenectomy may play a part in its management. Splenectomy may acquire to achieve diagnosis in the presence of palpable lymph node or to relieve the symptom of gross splenomegaly. Myelofibrosis results from an abnormal proliferation of mesenchymal element in the bone, spleen, liver, lymph node. Most patients present over the age of 50 years, and the spleen may produce pain owing to its gross enlargement or from splenic infarction. Splenectomy reduces the need for the transfusion and may relieve the discomfort resulting from splenomegaly. Splenectomy. Indication for splenectomy: trauma, accidental or operative, oncological, part of any block resection, diagnostic or therapeutic, hematological, spherocytosis, purpura, hypersplenism, and portal hypertension, like in variceal surgery. Preoperative preparation. The presence of bleeding tendency, transfusion of blood, fresh frozen plasma, cryoprecipitate platelet may be required. Coagulation profile should be near normal as possible at operation. Antibiotic prophylaxis appropriate to the operative procedure should be given. Technique of the open splenectomy. Most surgeons use midline transverse left costal incision and rarely thoraco-abdominal incision. Passage of NG tube to the stomach to empty the stomach when anesthesia introduced. In elective splenectomy, gastrosplenic ligament is opened up and the short gastric vessels are divided. The splenic vessels at the superior border of the pancreas are sutured and ligated. The posterior surface of the spleen is exposed. The posterior leaf of the renal ligament divided with long curved scissors, and the spleen rotated medially along the tail of and body of the pancreas. The pancreas is separated from the hilar vessels, which are normally double ligated separately and divided. Accessory splenic tissue and or omentum should be excluded by careful search at operation. There is no need to drain the wound if hemostasis is adequate. The segmental vasculature of the spleen does make it possible to undertake limited resection of the parenchyma. Hemostasis can be achieved by ligation of or application of metal clip to intrasplenic vessels and by careful application of low topical hemostatic agents such as fibrin pad. Conservative splenic surgery is therefore possible in some cases of splenic trauma and other pathology such as a splenic cyst. Technique of laparoscopic splenectomy. The patient is placed on the right side with the space between the left hilum and ilium and the costal margin exposed. Placement of access port is often determined by the size of the patient and the spleen. Insufflation of the abdomen can be performed once access is obtained through an incision 1 cm from the costal margin at the left midclavicular line. A further trocar is inserted close to the costal margin below the xiphoid sternum. A 12 mm trocar is inserted at the similar distance from the costal margin at the posterior axillary line. The splenocolic ligament is divided to give access to the lower splenic pole. The spleen separated from the kidney and the diaphragm before the gap between the splenic hilum and the tail of the pancreas is enlarged. The spleen is elevated to expose the splenic hilum, which is secured and divided within an endoscopic vascular stapler. 2 or 3 applications of the instrument may be required to secure the hilum and the short gastric vessels. Any remaining attachments to the diaphragm are divided before a self-retaining opening bag is introduced through the incision of the opening laparoscopy. After removal of the 12 mm port, the spleen is placed in the bag and the mouth of which pulled out of the abdominal opening before spleen crushed and retrieved with an instrument. The operation may be undertaken as a hand-assisted procedure, particularly when the spleen is grossly enlarged. Post-operative complication. Immediate complication specific to splenectomy include hemorrhage result from slip ligature, hematemesis from the gastric mucosal damage and gastric dilatation. Left basal atelectasis is common and pleural effusion. Adjacent structure at risk during the procedure include the stomach and pancreas. A fistula may result from damage to the greater curvature of the stomach during the ligation of short gastric vessels. Damage to the tail of the pancreas may result in pancreatitis, localized abscess, or pancreatic fistula. Post-operative thrombocytosis may arise, and if the blood platelet count exceeds 1 million per milliliter, prophylactic aspirin is recommended. Long-term surveillance program have emphasized an increase in risk of deep vein thrombosis and pulmonary embolism. The relative risk and benefit of thromboprophylaxis in this setting has not been assessed adequately. Post-splenectomy septicemia may result from Streptococcus pneumonia, Neisseria meningitis, Haemophilus influenzae, and E. coli. Long-term surveillance program has suggested that risk of pneumonia, meningitis, and major sepsis following splenectomy is increased threefold. However, the risk is greater in younger patients. In splenectomized patients treated with chemotherapy, and patients who have undergone splenectomy for thalassemia, sickle cell disease, autoimmune anemia, and thrombocytopenia. Opportunist post-splenectomy infection is a major concern. Published guidelines emphasize that most infection after splenectomy could be avoided through measures that include offering patient appropriate and timely immunization, antibiotic prophylaxis, education, and prompt treatment of infection. It is thought that children who have undergone splenectomy before the age of 5 years should be treated with a daily dose of penicillin until the age of 10 years. Prophylaxis in older children should be continued at least until the age of 16 years, but it is less well defined in adult. Furthermore, compliance is problematic in the long term, but at the risk of forming sepsis is greatest within the first 2 or 3 years after splenectomy. It seems reasonable to give prophylaxis during this time. However, all patients with compromised immune function should receive prophylaxis. Satisfactory oral prophylaxis can be obtained with penicillin, erythromycin, amoxicillin, amoxiclav. Suspected infection can be treated intravenously with this same antibiotic and cefotaxime, ceftriaxone, or chloramphenicol in patients with allergy to penicillin. Cephalosporin. The elective splenectomy is planned. Consideration should be given to vaccination against pneumococcus, meningococcus, and H. influenzae. The later two vaccines are commonly delivered as a combined preparation. Yearly influenza vaccine has been recommended as there is some evidence that it may reduce the risk of secondary bacterial infection. Such vaccination should be administered at least 2 weeks before elective surgery or as soon as possible after recovery from the surgery, but before discharge from hospital. Pneumococcal vaccination is recommended in those patients aged over 2 years. Haemophilus influenzae type B vaccination is recommended irrespective of age. A splenic patient should carry a medical alert and an up-to-date vaccination card. They require specific advice regarding travel and animal handling. Patients who have undergone splenectomy and are traveling to countries where malaria is present are strongly advised to use all physical anti-mosquito barrier as well as anti-malaria therapy since they are at risk of severe in splenectomy. You remember preoperative immunization, prophylactic antibiotic in the long term. Opportunistic post-splenectomy infection is a real clinical danger. Splenic conservation should be considered. Thank you.
شباب أحد عنده سؤال؟
شكرا جزيلا دكتور.
بعد عندنا محاضرة ثانية عن البارياتريك.
تمام دكتور.
دكتور ماجد،
تفضل
دكتور، بخصوص الفاكسين اللي راح ينعطي يعني بوست بلينكتومي، شلون يعني اول شيء بدايه من جيوكوكال وهيموفيلوس لو نيموكوكال يعني هذا الكومبينيشن؟
هو قبل كل شيء هو بالاصل احنا ننطي الفاكسينيشن بفور سبلينكتومي اتليست 2 ويك، بس بالامرجنسي ننطيه بوست سبلينكتومي. والله هو الافضل نعطيه يكون السبلين موجود حتى يصير الاميونايزيشن اعلى. واللي نعطيه هو يعني اكو 3 انواع من الفاكسين، المننجيوكوكال والنيموكوكال والانفلونزا اللي احنا ننطيه.
يعني دكتور هاي كلها ان كومبينيشن يعني يوز،
يعني هو اذا اكو ان كومبينيشن يستخدم، بس اكثريته نعطي كل واحد على حده.
زين دكتور، يعني السبلينكتومي يبقى يعني يستخدم لايف لونج انتيبايوتكس، يعني لو شنو يعني يستخدم نوع من العلاجات يكون لايف لونج؟
هو بروفيلاكتيك، يعني هو اذا كان اكو سيرجري اكو انفكشن اكو يستخدم البروفيلاكتيك، بس هو اتليست 2 years possibly نكتومي يستخدم البروفيلاكتيك.
تمام دكتور.
راح اذا ماكو سؤال شيء نتحول على المحاضرة الثانية اللي هي البارياتريك سيرجري.
بسم الله الرحمن الرحيم. Our lecture today is about bariatric and metabolic surgery. Learning objectives. What severe and complex obesity is rationale for surgery and the concept of metabolic surgery. Multidisciplinary assessment, the common operation and how they work. How to assess and treat perioperative complication. Follow-up, nutritional, supplement, and biochemical monitoring. Points. Surgical therapy is the only effective and proven therapy for patients with severe obesity, body mass index over 40. Bariatric operations prolong survival and resolve comorbid medical conditions associated with severe obesity. The availability of laparoscopic approach for bariatric operation caused a major changes in the field. Bariatric operation involve either restrictive of caloric intake or malabsorption of nutrient or both. Patients who develop a bowel obstruction after laparoscopic gastric bypass require surgical and not conservative therapy due to the high incidence of internal hernia and the potential for bowel infarction. Malabsorptive operations are highly effective in producing durable weight loss, but have considerable nutritional side effects. Patients undergoing such procedures require complete follow-up and must take appropriate nutritional supplements. The reason why a gastric bypass is the most commonly performed bariatric procedure, whereas the sleeve gastrectomy is the most rapidly increasing procedure worldwide. Introduction. Obesity becomes the plague of 21st century. Two-thirds of adults are overweight or obese. Obesity and lack of physical activity have the second largest public health impact after smoking. Severe obesity increases the risk of cancer. Most people, obese people, will be often of lower social class. Dieting increase in energy expenditure through exercise and intensive lifestyle intervention are successful for most obese people in helping them lose 6 to 8% of body weight. No available pharmacotherapy that is safe and clinically or cost effective in long term. Bariatric surgery is the branch of surgery involve manipulation of the stomach and or small bowel to aid weight loss. We can classify the obesity to normal weight, overweight, class 1 obesity, class 2 obesity, and class 3 obesity according to the body weight, body mass index. Conditions that are associated with severe obesity or complex obesity, type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, arthritis, gastroesophageal reflux, non-alcoholic fatty liver, polycystic ovarian syndrome, clinical depression, and functional impairment. The fact that American Medical Association waited until the summer of 2013 to acknowledge the obesity as a disease. Obesity is the second leading cause of preventable death in the United States. Etiology. Genetic and environmental factors contribute to the development of obesity. Intermittent or consistent excessive caloric intake, the lack of satiety. Obese individuals have excessive adipose cell both in size and number. Social stigmatization. Obese individuals are routinely discriminated against in terms of employment. Public facilities often do not allow them to participate in the activities. Examples include the size of airline seats and bathrooms, the availability of appropriate clothing option, and the size of automobile cabin. Thus, psychological disorders such as depression are found in an extraordinary high incidence in this population versus the general population. Poor self-imaging is the most universal among obese individuals. Metabolic surgery. The term refers to the marked effect of some operation on diabetes and the metabolic syndrome, which may have an impact more important than weight loss itself. The improvement in type 2 diabetes may be additional to the weight loss surgery. Is very cost effective since medication reduce or stop as glycemic control improve. Many surgical societies have added the word metabolic to their title. Example, American Society for Metabolic and Bariatric Surgery. Cost effective. The cost effectiveness of the bariatric surgery has been shown in studies from several different countries. A 2009 health technology assessment report in the United Kingdom showed bariatric surgery to be cost effective compared to non-surgical options. Prognosis. Bariatric surgery can significantly prolong the lifespan of severely obese individual, as well as improve the quality of that life. Medical management. The success rate for the severely obese patient population that try dieting and exercise as a mean for losing enough weight, about 3%. But all severely obese individuals are asked to attempt this route of weight loss prior to undertaking any surgical therapy. There are two main reasons for this. The first, weight loss through the safest possible means to do so. And the second, the lifestyle changes that must ultimately become routine for them once weight loss is achieved. Bariatric surgical procedure. Indication for bariatric surgery. Patient must have body mass index over 40 kilogram per meter square with or without comorbid medical condition associated with obesity, or body mass index 35 to 40 kilogram per meter square with comorbid medical condition. In addition, it is expected that the patient has failed attempt at medically supervised diet and be psychiatrically stable. Potential contraindication for bariatric surgery. Severe medical disease making anesthesia or surgery risky. Mentally incompetent to understand the procedure. Inability or unwillingness to be change life post-operatively. Drug, alcohol, or addiction. Active problem or bulimia or other eating disorder. Psychologically unstable and non-ambulatory status and supportive home environment. A pre-operative issue. Patient selection for surgery should be based on multidisciplinary team. Multidisciplinary team included bariatric physician, dietitian, specialist nurse, appropriate trained mental health professional, bariatric surgeon, anesthetist, radiologist, exercise therapist, and other like respiratory sleep medicine, cardiology. The nutritionist, careful assessment of the patient eating habits, knowledge, self-awareness, and insight are important. An estimation of the patient's motivation to change eating habits is important. The nutritionist should have at least one assessment session with the patient and an educational session preoperatively once the decision to proceed with surgery has been determined. Psychological assessment is required by most insurance carriers. One major benefit of the psychological assessment is to determine the patient's understanding of the operation and whether he or she has a realistic understanding of the changes that are needed in lifestyle for optimal outcome. The psychologist or psychiatrist often may diagnose previously unappreciated depression, which is prevalent in nearly 40% of our preoperative patients when carefully screened. Its treatment is felt to improve post-operative outcome. Some will decide against the procedure after through educational and counseling sessions. Inform and prepare patient will likely be much more compliant with the pre-operative and post-operative requested behavioral and eating changes. Pre-operative preparation. Preoperatively, current comorbid and other medical problems and their optimal therapy are confirmed. Potentially undiagnosed medical problems are sought. Screening for hidden disease. For patients with active jab on medication, a preoperative screening upper endoscopy to rule out Barrett esophagus and to rule out intrinsic lesion of stomach or duodenum is recommended. Patients who are on anticoagulation medication for prosthetic cardiac valves or history of recent venous thromboembolism must have their anticoagulation managed preoperatively. Options include total cessation of oral warfarin therapy 5 days prior to surgery, bridging this time with the subcutaneous low molecular weight heparin, or more rarely preoperative admission for IV heparin anticoagulation, which is then stopped 6 hours prior to surgery. Patients with a strong history of previous venous thromboembolism or who are felt to have multiple risk factors for postoperative venous thromboembolism are potential candidates for preoperative placement of temporary IVC filter. Some surgeons routinely perform screening ultrasound of the abdomen for patients planning to undergo laparoscopic Roux-en-Y gastric bypass with an intact gallbladder to rule out of potential presence of gallstone. When a patient does not have gallstone on preoperative ultrasound, use of prophylactic ursodeol in a dose of 300 mg twice daily will decrease the incidence of gallstone. Another value of the preoperative ultrasound of the abdomen is the assessment of the liver size and composition. An ultrasound that reveals a large fatty liver in a patient planning to undergo either laparoscopic gastric band or laparoscopic Roux-en-Y gastric bypass should alert the surgeon to the high potential for technique difficulty in the liver retraction and exposure. Some surgeons require patients to follow a low caloric diet in the immediate preoperative period, requiring weight loss prior to proceeding with surgery. Preoperative weight loss is not necessary to achieve good outcomes for surgery. Requiring preoperative weight loss raises the dilemma of whether patients who do not achieve weight loss should be then denied the benefit of surgical therapy. Another controversial area is the requirement for cessation of smoking by patient prior to undergoing surgery. Some surgeons make this an absolute requirement, while others do not. Baseline evaluation of thyroid function is indicated pre-operatively. Serum chemistries, liver function tests, and usual screening blood tests are done. Blood tests to determine baseline nutritional parameters are not uncommonly abnormal for low iron and vitamin D level. Preoperative education is important to inform important point of likely events of the perioperative period, expected post-operative course, and instruction for post-operative activity and diet. Expectation for the patient include ambulation on the day of the surgery, following post-operative dietary instruction, taking recommended vitamin and minerals supplements, and following a regular exercise plan. Regarding anesthesiology issues, this assessment confirmed the optimal assessment and management of ongoing comorbid medical problems. It is also include the aforementioned cardiopulmonary evaluation to determine any underlying pathology that requires preoperative treatment to decrease Preoperative morbidity from cardiopulmonary complication. Two major difficulties that the anesthesiologist faces when performing general anesthesia for severely obese patients are vascular access and airway management. Both are significantly more difficult in the obese patient population than in normal weight population. Management of severely obese patient airway is often a major challenge for the anesthesiologist and must be done well to avoid potentially significant morbidity. The anesthesiologist must be adept at understanding and managing alteration in cardiopulmonary function from the use of pneumoperitoneum during laparoscopic bariatric procedure. Specific anesthetic drug metabolic alteration in severely obese included a larger volume distribution of thiobentone, resulting in a prolonged effect of the drug. Type of commonly performed bariatric operations by mechanism of action. Primarily restrictive, example laparoscopic adjustable gastric banding, sleeve gastrectomy. Primarily malabsorptive biliopancreatic diversion, duodenal switch, and the combination like in example raw NY gastric bypass. Post-operative follow-up. Short-term follow-up is defined as follow-up of up to 2 years. The goal of short-term follow-up are to maximize care of the patient in the post-operative period, assist in adjustment to new eating, exercise, and lifestyle pattern. Be one of the alert for and treat post-operative complication and recommended measure to limit such complication. Medium-term follow-up is defined as that from 2 to 5 years. Long-term follow-up defined as greater than 5 years are the only means by which the true long-term efficacy of bariatric surgical operation can be assisted. A multidisciplinary team approach to follow-up is an essential, if not more so, post-operatively than pre-operatively. Regular counseling sessions with the nutritionist are always helpful. Psychological support should be available as needed to assist the patient in adjustment to major life changes. All programs should offer a frequent support group forum for patients to discuss issues on a less formal basis and receive encouragement from other patients as well as staff. These two diagrams demonstrate the outcome of bariatric operation and the effect of bariatric surgery on comorbid medical condition. This picture shows the laparoscopic adjustable gastric banding. And this is the two operation. The first laparoscopic sleeve gastrectomy, which is vertical sleeve gastrectomy, and the laparoscopic gastric bypass, gastric pouch, and jejunal anastomosis done. And this diagram demonstrates the major complication, estimated early surgical complication rates, operative mortality after gastric banding, gastric bypass, and sleeve gastrectomy, and late complication. Conventionally, bariatric surgery leads to weight loss of 25 to 35% of body weight, usually at least 15 kilograms after 1 year. Additional benefits are that most or all of the obesity-related disease improve as weight is lost. quality of life improve. Many studies have shown that bariatric surgery also effectively reduces cancer risk in large series of patients. Thank you.
شباب حد عنده سؤال شيء؟
دكتور بس بخصوص الثايرويد فانكشن بري اوب، دكتور شنو ظهر من عنده؟
الثايرويد فانكشن هو seeking for hypothyroidism اللي هو يسوي weight gain. وثاني شيء على مود يعني الانستيزيا يعني حتى يكون prepare well for البيشنت.
دكتور البيشنت اللي undergo gastric bypass surgery يعني post operatively شنو نتوقع يعني راح يختلف عن يعني الانسان الطبيعي؟ شنو اللي راح يفقده؟ يعني انه البنفيت راح يحصل انه راح يفقد الوزن، لكن شنو يعني الباد افكتس اللي راح تظهر عليه؟
هو اللونج تيرم يصير نيوترينت ديفيشنسي، يعني الباي باس نقصد احنا قصدت
يعني دكتور بصوره عامه يعني
هو مو هي كل سيرجري لها كومبليكيشن يعني تزيد بيها الكومبلي. بصوره عامه الايرلي هي اكثر شيء البليدنج الليك الاوبستراكشن. الليت اللي هي يصير نيوترينت ديفيشنسي، واكثر شيء يصير ويا المال ابزوربشن سيرجريز اللي هي مثل الجاستريك باي باس.
بالجاستريك باي باس يعني احنا هنا يعني مجرد راح نوصل تقريبا الاسوفيجاس بالجوجينم يعني
هو هي اسمها جاستريك باي باس انه تعبر الاستومك.
زين هنا بحاله شلون يعني شلون راح يصير الدايجستشن شلون هذا يعني شلون راح تصير؟
يصير الدايجستشن هو مو بس بالاستومك، ستومك يسوي تشيوينج يعني مثل يعني والدايجستشن والابزوربشن يصير كله بالسمول باول. لذلك هو بالباي باس راح يصير همنا فد يعني اتليست يجوز 2 متر من الباول يعني هم تنعبر يعني ويا الاستومك. راح يسوي الديستال الديستال تقريبا جوجينوم خلينا نقول يصير بيها باي باس، فيصير يعني مال ابزوربشن. والفكره هي اصلا مال ابزوربشن يصير
ويكون افويدبل ممكن يعني على اللونج تيرم.
هو راح يحتاج الى سبلمنت لايف لونج يصير سبلمنت.